So, Mark, one of the great debates in pre-hospital medicine is around giving volume to septic patients. So, on the one hand, we know that volume resuscitation early on, restoring perfusion, can improve outcomes. I recently attended a conference and heard a study where they suggested that, in fact, restrictive fluids were actually better for septic patients. How does that play out
Yeah,
in the EMS and the pre-hospital
I
world?
think I saw a tweet about that myself out of a recent air medical conference where the headline on one of the studies was fluid restriction is safe with many exclamation points after it, suggesting maybe we don't need fluids at all in sepsis. And I just gave a webinar recently titled Fluid Confusion in Sepsis because there's so much confusion about this topic. That study and many like it were actually done in the ICU hours and hours and hours after the patient originally presented in shock. It has nothing to do with the early minutes of care in EMS or in the emergency department. Yet, many of these studies are held up as evidence that maybe our preconceptions about fluids and sepsis have been wrong. Maybe we shouldn't use them. My advice is read the studies, look at the setting you're in, whether it's FEAST being done in Africa with children with malaria, which is not applicable to our setting, or the classic trial, which this tweet mentioned, which was an ICU study of fluid restriction in the ICU. And I would agree, yes, restrict fluids in the ICU. Let's don't give too much. But in the early moments of care, let's treat shock like it needs to be treated quickly and urgently.
So, Mark, let's wrap it up for our folks in the pre-hospital setting. When you have a patient who appears to be in shock and is hypotensive, what would you recommend regarding fluids?
I'd say fluids are the essential therapy they need at that moment. We give a measured dose quickly and observe the response and note whether we have improved blood pressure and perfusion, which in most cases we will. The patient in severe heart failure, for example, may be someone who may not benefit and actually could have an adverse consequence if we gave too much. But giving fluid in small doses and observing the hemodynamic response, mental status, cap refill, pulse quality, heart rate, blood pressure, if we see those things improving, we're doing the right thing. We can give another dose and know that we've made a difference in that patient's outcome.
So for our pre-hospital providers, if in doubt, give small controlled boluses to those shocky patients and let the physicians worry at the hospital
Right.
about the liters and liters that are being mentioned in
Correct.
some of these studies.
Our own protocols say give 500 ml boluses up to 2 liters and then start a vasopressor. Most of the time, pre-hospital providers are not going to get to that amount. So giving small doses, 500 mils, to try to reverse shock quickly is the best approach.
Perfect.